My mother was at the end stages of her life, and we had to take her to this hospital in California, in the United States, for blood transfusions. And at one time, we were waiting a long time in the admissions area, and I looked up on the wall and saw this sign, compassion. And in all of the bureaucracy and confusion in the admissions area, there was this sign that said, "We reach out to people in need and give comfort as Jesus did." So the hospital was setting this very high bar for themselves. And it didn't seem at the moment that they had achieved that bar, but it struck me that that was their desire. When you look at compassion and that word, we did a survey a few years ago of hospital websites in the United States, and more than half of them actually mention the word compassion on their website. Now, I don't think this necessarily corresponds to the level of compassionate care that they offer, but it was interesting to me that compassionate care seemed to be something that they were advertising in order to attract patients or to reassure patients. In global health, this field of health that's more interested or more focused on public health and population health, we don't hear the word compassion very often. And it seems curious that in public health, this word is not used very much. I began to be very curious about this because I was working in public health. And so I began to ask colleagues at CDC and other places, WHO, what is it that motivates and sustains you in this work? Can you say this in one word? And when my colleagues were willing to play that game, they would often visibly soften, and they would say words like care or compassion or even love. Well, we did not use those words in the halls of Centers for Disease Control where I worked for 20 years. So I became curious about this disconnect between what motivates us often and what we allow ourselves to talk about in our workplace. I'd like to share some thoughts about compassion because it's, in a sense, it's a simple concept, but it's also can be somewhat complex. And I think you're right, Dr. Frederick, that the notion of compassion or the understanding can differ from one place to another. One of the things that I found helpful is teaching by Stephen Post, a professor of ethics, who considers compassion to be an element of love. And in a shorthand, I often say that compassion is what love does in the presence of suffering. That's one way to think about compassion. Karen Armstrong, who is a scholar of world religions, after studying all the major world religions, said that the one principle that lies at the heart of all religious, ethical, and spiritual traditions is compassion. It's the one thing that links us as human beings in our faith traditions. There's a burgeoning field of compassion science. There's an Oxford Handbook of Compassion Science. And a lot of this work has been led by the neuroscientists who have studied what happens in the brain when we experience compassion. And this has led to certain training programs that allow us to respond to suffering with more compassion. And these training programs, based on these neuroscientific insights, have been subjected to randomized clinical trials showing their effectiveness. So this is relatively new in the last 20 years or so. One of the intriguing findings of compassion science is that the neural pathways in the brain for empathy differ from those from compassion, and that the empathic neural pathways, which are related to feeling the pain of another person, are associated with the pain pathways, whereas the compassion neural pathways, the prefrontal cortex and other areas, are much more related to the pleasure centers of the brain. And so this sort of dissection of empathy on the one hand from compassion in another is something I'll be talking about a little bit more. I'd like to share two models of compassion that have been used or developed in the psychology literature. Psychology has really tried to study the process of compassion, what happens when we are faced with suffering and we respond to it. Dagger Keltner, who is a psychologist at UC Berkeley in California, studies compassion in the psychology laboratory, and he's developed this algorithm or scheme which illustrates what happens when we are confronted with suffering. And this happens almost instantaneously. We go through these subconscious questions in our mind, he would say. The first question we ask is, who is the victim? Who's suffering here? Is this me or is this someone else? If it's someone else, he calls this person the target, then I ask myself, does that person's suffering satisfy my own goals? Now, if I treated you very poorly yesterday and you find that I'm suffering today, maybe you'll feel good about that because I'm getting what is my due today. But if we decide, no, this person's suffering doesn't satisfy my goal for myself, then we ask, is this person deserving of my help? If we don't feel that someone is deserving of our help, we're not going to offer them compassion. And then the next question, if we feel that you are deserving of my help, is, do I have the resources to cope with your suffering and to actually help you? And if I don't have those resources, I might feel distress. If I can do something to help, then I move into compassion. There's a lot of things to discuss with this algorithm. You might object to many of the parts of it, but it's an example of what's used in the psychology laboratory to tease out different elements of the response to suffering that is compassionate. Another model that I'd like to share and that we use often in global health and in our teaching is from social psychology, and they focus on three main components of compassion. That compassion is not one single thing, but it involves these elements of awareness, empathy, and action. In order for us to respond to the suffering of another person with compassion, we have to actually be aware of their suffering. We have to understand that they're suffering. There's a cognitive process or attunement with that person. We have to have a stability of mind, and our memory of maybe our own suffering may help with that awareness. Now, in clinical practice, we see the face of the person. In global health or public health, we're often dealing with numbers, and so we may not have the same awareness of suffering. If we are aware and we're morally sensitive, then that will arouse empathy or a sense of feeling the pain of the other person, emotional resonance. Now, at this point, particularly in clinical situations or in situations of intense need or suffering, the aspect of emotional regulation is important. If I am in the presence of intense suffering and I become myself distressed, then I might go, rather than compassion, I might focus on my own distress and go into a fight, flight, or freeze response. I might avoid the suffering. Or I might get very busy and do things to alleviate my own distress that may not be effective in alleviating the distress or the suffering of the person I'm there to help. So if I'm able to be present to that person's suffering, but not be overwhelmed by it, and not put distance between myself and that person, then I'm able to go to a compassionate response and act in a way that effectively alleviates that other's suffering. And then in this model, there's a final element, which is to not be too attached to the outcome. Because if your healing becomes my objective and I over-identify with that, then that can create some challenges for us as well. So there's an element of doing all that we can to alleviate suffering, but not being too attached to the outcome. Another view of compassion from the theologian Henry Nouwen, in this beautiful book by Philip Larkin on compassion and palliative care. Nouwen says compassion asks us to go where it hurts, to enter into places of pain, to share in brokenness, fear, confusion, and anguish. So that's that empathic response, to be present to suffering. It means full immersion in the condition of being human. So this is an unguarded response to suffering, being able to be in the presence of suffering, to share in pain, but not be overwhelmed by it. We're doing some work now to explore the role of compassion and flourishing in healthcare. In a very simple model, some form of suffering or illness, disease, brings people to seek healthcare. They seek alleviation from that suffering. And we believe that compassionate care actually leads to greater human flourishing. And that the absence of compassionate care actually can decrease human flourishing. And we're exploring this relationship. There's a lot of work recently that demonstrates and marshals the evidence for the role of compassion in promoting human flourishing. Stephen Treziak has reviewed the data in this very nice book called Compassionomics that shows benefits of compassion for the patient in terms of health, enhanced self-care, improved quality of care that they receive, greater immune response to interventions. It's also very positive for the healthcare provider, personal satisfaction and well-being. And it's also better for the healthcare system as a whole in terms of patient experience and quality care, even better financially. I've had the opportunity to look at your website, and I'm so impressed with your work. I think your vision really speaks to this importance of human flourishing. And your mission is one of compassion, in that particularly the action component of compassion, you actively seek solutions and you act on the health problems, but you're also aware of the suffering that's related to the health problems in your area, and the way you're doing your work, this open and inclusive platform, demonstrates the action of compassion and the empathic response you have to the people in your area. The importance of action is illustrated by this lovely quote from Gustavo Gutierrez, who is a Catholic theologian from Peru, saying the concern for effective action is a way of expressing love for the other. These are not separate things. Now there's several challenges to compassion in clinical practice, and you probably experienced these yourselves, and you may be more familiar than I am with these pressures. The pressures of time, the stress and burnout of clinical care and of being in the presence of suffering, particularly where we don't have resources to alleviate it. We might be overloaded by the empathic response to suffering, and there might be issues of moral distress where we're in the presence of suffering and we can't alleviate that. There's also organizational and systemic challenges to compassion. Particularly here in the United States, healthcare has become a commodity and a business, and the for-profit motive has overtaken the compassionate motive. We work in systems that are often very unsupportive, both of patients and of the healthcare providers. And particularly with COVID, there's been a breakdown in the social contract where people who refuse vaccines think that the whole COVID story is a hoax, and distrust and fear healthcare providers. This makes it even more stressful to maintain compassion in clinical medicine and healthcare. And in public health or global health, we also have challenges to compassion. When we're working with populations, our information on suffering becomes tables and graphs and data rather than seeing the faces of individuals. And we work at great distances sometimes with people we'll never actually meet. And this makes it hard to have an empathic response to the problems that they're facing. We also work in complex bureaucracies and partnerships, not to single out any ones in particular here, but often in these complex organizations, the emphasis turns away from the mission of alleviating suffering and towards maintaining the bureaucratic or institutional structures. So this can dilute our compassionate impulse. And we often face competing values. Global health as a field is deeply influenced by foreign policy objectives, political objectives, military interests, which may diverge from the simple objective of alleviating suffering and promoting flourishing. And so we have these divided loyalties. Is the organization that's paying my salary, do I work for them or do I work for the patients and the people whose health I'm trying to improve? What do we do when these interests diverge? It might be helpful as we look at a few critiques of compassion in global health to consider the spectrum of responses to suffering. On the one hand, we have what I would call a mature compassion, grounded in solidarity and humility. And on the other side, the far enemies of cruelty or indifference. There are also what I would call near enemies, responses to suffering that might look like compassion, that might claim their compassion, but they're immature and they are not true compassion. One of the two critiques of compassion in global health that I'd like to mention is from Didier Fassin, who is a French physician, a French philosopher. He claims that compassion, particularly in the public sphere, is an expression of superiority, that it presupposes a relation of inequality. It's directed from above, from the more powerful to the more vulnerable. It's directed from above to below. So I'm compassionate. I will give you my compassion as a powerful physician, and you'll be grateful for it. He's saying this is compassion is an expression of superiority, and we should do away with it in global health. I think he's talking about pity, which is an expression of condescension, where I'm better than you and I will give you the benefits of my compassion. That is not mature compassion. It's not the compassion that we learn about in our religious training or even in our own experience. Another critique of compassion in global health is that it's an unstable emotion. Several philosophers have said that ethical decisions should be based on reason. We need to get rid of emotions like compassion, and if we rely on them for public policy, we're in trouble. Susan Sontag and Paul Farmer use this term, unstable emotion. The result of this is that it privileges people who are like us or people that we can see, and this position would argue that compassion actually promotes inequality and injustice. Well, here again, I think we're talking about a distortion of true compassion. We're talking about sentimentality, which is detached from justice. And it goes against the public health value of seeing all people and reaching out to where they are rather than having them just come to us as we sit in our offices. I believe that compassion and justice are, in a sense, two sides of the same coin. And the theologian Roger Haidt has said that to be compassionate for all, which is what global health requires and what our religious traditions require, means that we're also concerned for justice. That compassion in the public sphere means that we're concerned for rights and for justice. Now there's some rays of hope for compassion in global health coming from the World Health Organization. Recently, Dr. Tedros has included compassion as a key element of healthcare quality. It doesn't just take planning and investment and monitoring, but also compassion. So compassion is being seen in more increasingly at WHO as an essential element of quality healthcare. The Ethiopian Ministry of Health has, in their health sector transformation plan, developed a pillar for caring, respectful, and compassionate care. And they're one of several countries that have brought compassion in to the objectives and the fabric of the national health system. We have, with WHO, quarterly global health compassion rounds, webinars that are open to anyone who's interested, and we focus on the role of compassion in relation to different aspects of global health: palliative care, water sanitation and hygiene, mental health, neglected tropical diseases. And we go in depth with people from around the world to explore the role of compassion in these different aspects of global health. And so I sense a community of practice beginning to form. If we're going to embed compassion in our healthcare systems, how do we measure it? How do we train people to become compassionate? How do we evaluate what's happening between a provider and a patient in this case? Compassion is difficult to measure, but if we're going to have it as part of our systems, we need to try. And I'd just like to share a few thoughts on measuring compassion. There's three different perspectives. This first person, where it's self-reported; second person, where someone else can evaluate whether you're compassionate; and a third person, whether you're basically based on observation, an objective measure of compassion. The most common measure, unfortunately, really is a self-reported questionnaire. Are you compassionate? Well, many of us in healthcare would say, yes, I am, of course. And there are several different scales. The Santa Clara Compassion Scale is one of the most popular. It's just 5 simple questions shown here. And these have been used to assess self-reported compassion. Now, we know that self-reported compassion may not be always reliable. So what if we ask patients, did you receive compassionate care? Here again, there's several validated questionnaires that have been developed. Here's a simple one that includes 5 questions for patients, and these can be included in exit interviews for patients to give you a sense of, are the patients experiencing the care as compassionate? Now, Shane Sinclair, a chaplain and researcher in Canada, has explored how patients perceive whether their provider is compassionate. He studied a couple hundred palliative care patients, and when they were asked, did you receive compassionate care? And if so, how did you know that? You can see their responses, how these patients understood compassion was that as a virtue, as a virtuous response on the part of the caregiver. That the caregiver was relational. They communicated effectively. They asked about them as a human being and a person. So the patient's understanding of compassion is actually quite nuanced and quite complex. And then finally, there is a third person or observer measure of compassion. And my favorite example of this is a study done back in the 1970s with seminary students at Princeton Theological Seminary. They were asked to either give a talk on the Good Samaritan or on another topic, and they were given some time to prepare that talk. And then they were asked to go to another part of campus for giving that talk and continuing with the exercise. As they had to walk across campus, there was a man, an actor, who was shabbily dressed and laying in the gutter in an alley, and he was obviously in pain. And half of this group was told, you need to get to the other part of campus in 10 minutes, where you need to hurry. The other group, they said, you can take your time. Being asked to give a talk about the Good Samaritan made no difference as to whether these seminary students stopped to ask if that person needed help. What did make a difference, a 6-fold difference, was whether they felt pressed for time or not. And just like in the story of the Good Samaritan, the parable of the Good Samaritan, those who were pressed for time and busy, felt too busy to stop, did not do so. So compassion takes time, and that's often in short supply in our medical and public health settings. Let me see if I can go to the next slide. There we go. Let's talk very briefly before I end and look forward to your comments and questions. If we are interested in cultivating compassion, how do we go about this? Well, clearly we have a lot of resources and examples from our religious traditions, and so religious practice and spiritual reflection are really powerful tools to cultivating compassion. Just living life, being in relationship with other people, family members, can be very strong, powerful instructors as to when we are compassionate, when we need to be more compassionate. One of the most important things in our busy lives is just pausing and setting intention, perhaps between patients, remembering, why am I here? What is my commitment in this moment to this next patient that I'm going to be seeing? I think noticing when we're not compassionate and being curious about it can also be a very powerful teacher and instructor. And this being curious requires a level of self-compassion. To be able to say, I was not compassionate in that moment, and to be curious about it and try to understand it rather than condemning myself for that, is important to being on the pathway to becoming more compassionate. And then increasingly there's compassion training available, largely based on some of the lessons from the neuroscience. But there's also training now available in compassionate leadership, and these are often now available online and are available to folks around the world. Compassionate organizations often have compassionate ethical leadership, and there's some empirical evidence to show that compassionate ethical leaders instill compassionate practices among the staff, largely through their example, but also through policies. Compassionate organizations notice when members are suffering, and they facilitate coordinated actions to alleviate that suffering and to support each other. The organizational culture of compassion emphasizes belonging of each person, communication that is sensitive and compassion, and that has a compassionate mission. Now, my understanding from your website is that you are an example, a shining example of a compassionate organization, dedicated to compassion in the service of human flourishing. And I just want to thank you for your work and for the wonderful work that you're doing, and for the opportunity to speak to you as you promote human flourishing both in your area and around the world. I'd be very happy to hear from you, to be in correspondence with you, and it's just such a pleasure to speak with you, and I look forward to questions, comments, and our conversation. Thank you so much.